All right, everyone, welcome back here. This is the final case of this third board review. For this, we're going to have a little surprise. We're going to do a little lightning round of multiple choice questions. So it's not going to be a single case. It's going to be 10 multiple choice questions. So just think about the answers as we go along. All right, so our first question is, what sequence, so MRI sequence, is most vulnerable to variations in the B0 magnetic field? So is that going to be diffusion-weighted imaging, fast-spin echo T2, fast-spin echo T1, or a GRE? So think about that for a second. So the answer to this one is going to be diffusion-weighted imaging. The reason diffusion-weighted imaging is more susceptible to variations in the field is because it's an echoplanar technique, so you get the entire slice in one TR. You have no refocusing, and it's very vulnerable to field variations. So that's why it's bad around braces, metal, dental hardware, around the base of the skull, around bones and sinuses. So you'll see that with diffusion-weighted imaging. All of these fast spin echo techniques have refocusing. Gradient echo is also a little bit vulnerable to susceptibility as well. So that would be your second choice here. Your second question is, which of these parameters is most likely used to generate a sagittal T1 weighted image? So you have a couple of options here that you want to take a look at. Generally speaking, you're trying to think about, do you want a short echo time? Do you want a longer echo time? Do you want a short TR? Do you want a longer TR? And what kind of flip angle do you think you might have? This fourth one here has an inversion portion of the sequence there. So for this one, what you're looking for is A here. So this has a TE of 10 milliseconds, a TR of 500 milliseconds, so kind of an intermediate, but you have a complete flip angle, so you flip things completely into the transverse plane there, whereas something like a GRE sequence has a smaller flip angle. Now, I don't think you have to know these things exactly, but you do need to know, for instance, that T1 sequences have relatively short TE and TR, T2 sequences have relatively long TE and TR, and sequences like flare and stir have an inversion pulse in front of them. And you guys can check this out. There's a variety of websites, but this link from Radiopedia is actually a nice overview where you can see what those sequences are like. Your third question is, which of these masses is most likely to be angiographically occult? Is that a meningioma, a cavernous malformation or cavernoma, an AV malformation, or a metastasis? So your answer to this one is a cavernous malformation, and these are the classically described angionegative masses or angionegative vascular malformations. They're abnormal capillaries, and they really don't have enough enhancement to be seen on angiography. So most of the time you don't see them on angio. You don't really see a whole lot on post-contrast MR or post-contrast CT. So these are the angiographically occult vascular malformations or cavernomas. Question 4, in a patient with vocal cord paralysis, what extra precaution do you want to do when you perform a neck CT? So do you want to get some additional delayed phase? Do you want to get a thin slice soft tissue? Do you want to not use contrast, or do you want to image inferiorly into the upper chest? So your answer on this one is that you want to image inferiorly into the upper chest. You need to go all the way down to the AP window at the level of the aorta. This is because you can have upper chest masses that disrupt the recurrent laryngeal nerve, and that can cause vocal cord paralysis. So you wouldn't want to miss a mass in the upper chest because your neck CT doesn't go down far enough. Question 5. If a patient with serious concern for Cauda equina syndrome cannot have an MR, what is the next test of choice? You want to do radiographs? You want to do a non-contrast CT? Do you want to do a CT myelo? Or do you want to do a bone scan? So there are two relatively reasonable answers here, with those two being the non-contrast CT or the CT myelogram. If you look at the ATR criteria for suspected Cauda equina syndrome, your first two choices are going to be without contrast MR and a with and without contrast MR. And so that's really like the first thing that you're thinking about. If MR is non-diagnostic or contraindicated, the myelogram is slightly better than a non-contrast CT. However, in many places, it's going to be time consuming to get a myelogram. You're not going to have immediate access to a myelogram. So you might think about getting that non-contrast CT before you proceed. So on this one, the correct answer is going to be a CT myelogram. I think if you were thinking about B, that's relatively reasonable as well. Question 6. A fracture of the orbital floor is most likely to affect which cranial nerve? So here you have the 3 sub-branches of cranial nerve 5, or the trigeminal nerve. Here you have cranial nerve 6 or cranial nerve 7. So you need to be thinking about which one of these goes through the orbital floor. So it's the second segment of cranial nerve 2, or the V2 segment, that goes through the infraorbital foramen. If you have an orbital floor fracture, it can go through that infraorbital foramen and can injure that second portion of the trigeminal nerve. This can cause pain or sensory abnormalities in the ipsilateral face. So just be aware of that if you have a fracture of the orbital floor. Question 7. What is the appearance of hyperacute blood on MR? So this one is you got to think about like how blood evolves over time. And your question or your options here are really, you got to think about T1, like what is T1 likely to look like? What is T2 likely to look like? And how's it going to be evolving over time? Like, is it bright? Is it isointense? And so forth. So when you're thinking about that, you want to think about what happens over time. And on CT, like it tends to be very bright and then gradually get darker. On T1, it tends to be isointense at the beginning. Once it becomes methemoglobin, it becomes bright. So you don't get that brightness on T1 until a little bit later. The T2 is really affected by the surrounding environment of hemoglobin. So it tends to be very bright in the hyperacute phase, get dark for a little bit brighter again once the methemoglobin is extracellular. And then later, like it tends to be dark on everything like T1, T2, and CT. So if you're hyperacute, you really need to be thinking that it's isointense on T1 and hyperintense on T2. You can think about this graph, and this graph is also taken from Radiopedia. So here you see like when you kind of start out, you sort of at the immediate time of the hemorrhage, you're kind of T2 intermediate to bright, and then you kind of move here to a little bit darker over time. Once you start forming methemoglobin, then it kind of goes around in this circle here. So you guys can review that on Radiopedia, but just think about the evolution of blood over time. So that's the answer is going to be that it's T1 isointense and T2 hyperintense. Question 8. What causes diffusion restriction when strokes occur? So strokes in the brain. Is it disruption of cell membranes allowing water to leak out? Is it failure of sodium-potassium pumps allowing water to leak into cells? Is it VEGF release? Or is it mitochondrial failure with cytochrome release into the cells? Just think about that for a second. All right, so the cause of diffusion abnormality in strokes is that metabolic failure causes the cell membrane pumps to fail. So they're not getting adequate ATP to pump ions and sort of maintain the normal ionization. When this happens, ions collect within the cells. They bring water with them. The intracellular water goes up and the extracellular water goes down. Intracellular water is more restricted because of the cell membranes. So what you're going to see is less water movement, and that's going to give you brighter signal on your DWI and low signal on your ADC, or low values on ADC. Question 9. What is the diagnostic reference level by ACR for a head CT in an adult? So I've given you 4 values here ranging from 25 to 100. It seems like those values are relatively close together, but this is something that you need to know. So this is a table from the ACR of the diagnostic reference levels, and the diagnostic reference levels in this column here. And that's typically the level below which the vast majority of your scans of that type should be. For an adult head, that reference level is 75. So when you're looking at a head CT, most of the time that's reference level, or the CTDI is going to be about 45, 50, 55, something like that, but it should generally be less than 75. For the others, these are a couple of others that I think you need to know. The adult abdomen pelvis 25, pediatric head 40, pediatric abdomen 20. So probably like this is something to take a look at maybe right before your exam. Take a look at these reference values just in case one of those comes up. So the answer to this one is 75, as we discussed here. So your final question here, what is the rate of severe anaphylactic reactions after administering MRI contrast? So all of these values are relatively rare here. Is it more than 1%, 0.1 to 1%, 0.01 to 0.1%? So when you think about it, this would be more than 1 in 100. This would be 1 in 100 to 1 in 1,000. this would be 1 in 1,000 to 1 in 10,000, or this would be less than 1 in 10,000. So you can find the answer to this in the ACR contrast manual, but severe life-threatening reactions to contrast are exceedingly rare. They had a study of about 687,000 doses, and there were only 5. The study of 20 million, there were about 55. So it's typically less than 1 in 100,000. So that's relatively rare. So I hate to be picky about numbers like this, but these type of questions tend to appear even when they're specific. So just remember the MR contrast reaction rate is very low, less than 1 in 100,000. All right, that's the last question that we have in the last part of this Board 3 board review. Be sure to check us out on learnneuroradiology.com. You can follow me on Twitter and be alert for any of the new cases that are going to be popping up. We're going to try to get more material on here more frequently. So thank you guys for watching today. Be sure to hit the like button and subscribe.